Hello, everyone. I'd like to thank you for the opportunity to speak today, and I'm going to be presenting on how active post-discharge surveillance programs decrease ED visits and readmissions for ERAS for colorectal ERAS patients. So to begin, I have no financial conflicts of interest or disclosures to report. So some background on active surveillance. Active surveillance is essentially where you essentially a way for you to communicate with your patient remotely. It's a form of telemedicine. And there was a French study of 100 patients that showed that there are benefits of coupling ERAS with active surveillance. It was a text message-based only program that didn't provide pictures to the patients, but it provided, it allowed for timely detection of postoperative complications, as well as it showed that there were low ER visit rates, as well as a quick response time. And in 2016, there was a University of Wisconsin-Madison study of 14 patients that essentially looked to see if adding images into the mix would allow for patients to be satisfied, as well as if these were diagnostically applicable to diagnostics. So the APDS that we used was called Twistle. It's a mobile phone application that is HIPAA compliant and allows for messaging between the patients and the care team. It's an independent company, and in March 2016, it was implemented at Advocate Lutheran General Hospital. It's a HIPAA-compliant way. It's a HIPAA-compliant form of communication by text and photos to various care team members, which would include physicians and their office staff, as well as nurses and visiting nurses, and their care coordinators, extended home health care nurses, and so on. So the way Twistle works is it provides an essentially it uses these workflows, which are these automated surveillance questionnaires that patients will get like a daily question of how are you feeling, how much fluid have you taken over the past 24 hours, so on and so forth. And it will alert the care team if the patient's not responding or if something's off. And we believe that 90% of these alerts are first managed by office staff and nurses, and only 10% of these actually get escalated to the surgeon. And of course, it also provides for oversight of extended care facilities and home health agencies. So the aim of our study was to evaluate the impact of an active surveillance program on 30-day postoperative emergency room visits and readmissions in colorectal surgery patients that were on the ERAS protocol. So we looked at patients between March 2015 and March 2018, and when it was implemented, these patients were eligible to be in the ERAS APDS group, although not all patients after March 2016 were included, because not all patients utilized Twistle properly, so those patients were eliminated from the study, or they were grouped with the ERAS-only group. So this was a retrospective chart review at a single center tertiary care hospital, to give a size estimations of 645 bed hospitals, and we looked at right, left, subtotal, and total colectomies, as well as low anterior resections for over 4 colorectal surgeons. We looked at 393 patients, and we assessed their participation in APDS. Also, we looked at the number of ED visits and readmissions each patient had within, at or prior to postoperative day 30. Of course, we assessed population demographics such as length of stay, comorbidities, smoking status, as well as gender and age. So in our study, we defined a SAVE. So a SAVE is an instance where an interaction between APDS and a patient and healthcare provided may have prevented them from going to the emergency department. So essentially using this program to say, hey, you don't have to go to the emergency department, or you have to go to the emergency department. We also assessed avoidable encounters, which included superficial surgical site infections, as well as leaks around JP drains. So we found that in our study, we had 194 patients who were ERAS only, as well as 199 ERAS patients that were utilizing APDS properly. So we assessed length of stay. There's actually a significant difference between length of stay amongst the two populations. This was on average about 1.5 days, and these patients, essentially 1.5 days, they stayed at the hospital 1.5 days shorter. We found no significant difference between major and minor complications amongst the two groups, although there were more major complications in the ERAS-only group. When it came to ED visits as well as readmissions, I'll show you guys in a moment, there was a statistically significant difference where there was 10 less patients in each group that were readmitted as well as visiting the emergency department. Let's see here too. When we assessed saves, we found that 18% of APDS interactions, or 18% of patients in the APDS group had interactions that we were able to classify as saves. These instances ranged from reporting bloody bowel movements to dealing with high fevers or just simply sending a picture of an incision site for the surgeon to check on. We felt that the resultant patient peace of mind was typically quite apparent, and these patients did not go to the emergency department because of their ability to communicate with their care team via the APDS. So in summary, we found a significant decrease in emergency department visits and readmissions for patients on the ERAS protocol, as well as utilizing active surveillance. 18% of APDS patients likely averted an emergency department visit, as well as length of stay was approximately 1.5 days shorter for APDS patients. So we believe that active surveillance is a valuable ERAS adjunct. So in conclusion, of course, there's an impact on ERAS patients' readmissions within 30 days. As well as we believe that ERAS and APDS should conserve emergency department resources, healthcare costs, patient, physician, and as well as care team time. We believe that APDS provides patients with peace of mind, which allows them to avoid an uncomfortable visit to the emergency department, which is of course stressful. And in the future, we plan to do a NSQIP data review of our institution. And the preliminary results of this review are consistent with our results I'm presenting here today. Also, we hope that APDS will be offered in multiple languages, such as Spanish, Polish, Russian. Also, we plan to do a prospective comparison that utilizes a dedicated research team and also look at multiple socioeconomic strata because, of course, of the limitations of a retrospective study. And there are also plans for a multi-institutional review with programs in Washington and Florida. Thank you.
Can I go ahead? Yeah, Dr. Baccarelli from McGill. Congratulations on the study. I was just curious, how do you think an active surveillance, which is post-op, justifies a decrease in length of hospital stay, probably just because it was it was afterwards during a more mature implementation of enhanced recovery probably, but maybe you have another justification. And the other question, who is actually receiving the saves? Who's looking at it? Because if I think about it, and if I'm the surgeon and I receive a save or a picture from the patient and it's midnight, what am I going to do about it? So is there a certain person who's receiving the calls and the images?
Yes. So to answer your first question, we found that there was a difference between the lengths of stay, and we believe that this was due to we believe that there's a possibility that essentially both patients and surgeons felt more comfortable to send these patients home earlier because there was a way to communicate if something was going wrong with these patients, as well as for your second question of how this works. So essentially there are these workflows, and at first if a patient generates an alert, they send it to like a care team. So there's someone 24/7 to answer these questions, and then they can this care team can escalate these alerts to the surgeon, as well as the surgeon can of course view any of these alerts that they so wish, but they get a notification that like, hey, something's wrong, please take a look at this, and then sometimes they resolve this over text, or sometimes they'll call the patient, depending on what's easier and what they prefer.
Thank you.
I just want to, I'm Savi Merchik from Chicago. I'm one of the senior authors. I want to thank you for the questions. I want to thank Dan. He's a college student, so if someone is interested in opening the medical school doors, he's a good candidate. But thank you for that question. I just wanted to I agree with you that there is this maturity of the program, and ERAS is a multi-component system. And each component is still being matured, essentially. So, but I don't. The purpose of this study is really to give us something to think that it is practical. It is feasible. We only get 10% of those questions from the patients. I think that the hospital should consider putting it in their ERAS program, essentially. It's not a very expensive thing. We still, this was a trial, so we don't have the final price of the product, essentially. But this is not going to be expensive, probably $10 a patient, you know? But it really, I think it influences your decision about discharging the patient. What is happening right now, we estimate that about 30 to 40% of colectomy patients we send home in less than 23 hours. This is the most recent data, the last 6 months essentially. And it gives you this, you know, I can monitor this patient. What if the patient leaks? Okay, well, you know, we have some tool, the fever is going up, the patient can check their temperature, the patient can check their heart rate, something is not right. You get the signal, and then you send them to the emergency room. Now, what is interesting, and this is something that we're also about to investigate it, I think that the cost of readmissions can be really decreased by this tool, because what you do, you don't send this patient to the emergency room so they wait for 10 hours with the leaking abdomen, with the leaking anastomosis. You send them to the floor, and then you start the process with the residents who are, you know, waiting. You send the patient to a CAT scan, you just stratify this. I think it's so we can really argue that if you send the patient 23 hours, if this patient comes back with the readmission, the cost of the readmission is not going to be the same as we think or what is happening right now. So many avenues to go, but thank you very much.
Slavi, I have a quick question for you. I appreciate that you're saying it's only $10 a patient, but what do you say to your administration to get them to buy a product like this? And have you seen a cost benefit overall with this 18%?
So,
to justify?
Yeah, Debbie, we definitely see the cost with ERAS. It's less 40% less than it used to be. It's difficult right now. We don't have the data exactly how much it costs.
Okay.
So it's a project, next project. The hospital administration right now is actually the only one that are continuing this program. They're going with some inferior, in our opinion, inferior platform that does not allow you to have the same options as here. So they're seeing the value of it, but it's just the politics right now, you know. So I think it just remains to be seen. There's many products showing up. Don't ignore them. It gives you this extension into the patient, you know, into the patient home, and I think it's important.
Thank you.
Thank you.
If anyone has a med school spot for him. Thanks very much. Nice job.